weekends. Okay, great.
Yeah, that's fine. It's cool. Okay, so my first question is, do you accept insurance for psychiatric care?
Good question. So the way that I set up my practice, it's a direct pay practice. So meaning I don't contract with any insurance companies. Instead, I post my fees online, and then people, when they find me on the internet or through referral, they actually just pay me directly. So I put my price list up there, and then they can take that receipt and submit that receipt to their insurance company to see if the insurance company will pay them back. So instead of me, so in other words, instead of the claim coming through me and me billing on a person's behalf, they just I collect payment up front and then they bill on their own behalf.
Okay. And what's the reason for doing that?
Oh, because number one, it's much easier. Second of all, so people have a fundamental misunderstanding of what insurance companies are. So an insurance company is a business whose goal is to make money. Because that's the goal of business, is to turn a profit. And so what insurance companies do is they create a group of products that people can buy into in the form of insurance. And then the insurance company's goal is to then keep as much money as possible and not to let any more money go back out.
Yeah.
And so the insurance then has a vested interest in making sure that the contracts that they have with doctors like myself is as conservative as possible. So a lot of doctors, when you get into a contract with the insurance company, it's not written in the doctor's favor. And then they build in a whole bunch of stuff about timeliness of claims, and then what they will and will not cover. But you never know that up front. Most times you don't learn it until they deny your claim. And so a lot of doctors who are on insurance panels are getting their claims denied, or they get paid 30 to 90 days late, which means that you can't run a practice because you have staff to pay for, you have other financial obligations. So that's why I don't take insurance. I will probably never take insurance. And I think the insurance system itself is skewed because of the way that we set it up.
Okay. So since you don't deal with insurance directly, do you know anything about how, when people bring like their claims back, how insurance works with them?
Yeah, keeping in mind that an insurance company is a for-profit endeavor. Now, there are some not-for-profit insurance companies, but if you think about it, a not-for-profit company they still need to make a profit because they have staff to pay for, so they still need to make money. It's just what you do with your profits after you've paid your bill. So, in any case, when I just forgot your question because I got sidetracked.
Oh, it's okay. Actually, I didn't necessarily have a question yet. I was just asking if I could ask questions about that topic mostly.
Oh yeah. No, you're fine. Yeah, but you asked something. Oh, what was it?
It was like, do you know how insurance works when they bring their claims back?
Oh yeah. So it actually works better. So the insurance company has a vested interest in keeping their customers happy, keeping the people who pay insurance premiums. They want to keep them happy, and so they will actually pay claims back to the patient, whereas they wouldn't give it to doctors. So in other words, like I said earlier, sometimes they wait 30, 60, 90 days to pay us. They don't do that with their actual customers, because if they tick their customers off, they're going to leave and go to Cigna or go to another place, right? So a lot of my patients, when they submit their receipt to the insurance company, they get 50, 75, sometimes 100% of their costs back.
Wow.
So a lot of people don't mind filing insurance claims at all because it's so easy. And there are now other companies to file on your behalf. They will literally take all your information, submit that information to your insurance on your behalf, so that then you don't have to do anything, and then they get paid on a percentage of what you get back. And there's at least 2 or 3 companies. There's one that I always kind of recommend to my patients, just because it makes it a lot easier. But insurances actually do pay patients back, but they don't pay doctors.
Wow, that's kind of crazy.
It's messed up, yeah. And so that's another reason why a lot of doctors are saying, forget it, I'll just get out of the system completely.
Yeah, that's good. So then, I guess that's kind of answered. How common is it for patients to supplement their prescriptions with psychotherapy?
It's not as common as it should be. So I'm weird because I am a huge advocate for everybody having a therapist. So every time I go out and give a lecture, no matter what I'm talking about, I always talk about the fact that every person should have a therapist because you're too close to yourself to be objective. I've had a great therapist who helped me recognize that there are certain times in my life when I have certain thought patterns that are not very helpful.
Yeah.
And we all do that. It's just right now there's such a huge stigma attached to it, and so I would like to see everybody supplement their medical care with a therapist, with some type of mental health person. It doesn't mean you have to be on medicines. It doesn't mean that you're crazy. It doesn't mean that something's wrong with you. To me, it should be included in your yearly like well child or well person checkup. That's how common having a psychotherapist should be.
Okay.
Yeah.
And do you ever perform psychotherapy yourself?
Oh yeah, it's great. Yeah, so the term psychotherapy is a really huge term because there's lots of different types of therapy. So there's some of the more common ones are CBT, so cognitive behavioral therapy. There's behavioral therapy. There's cognitive therapy. There's solution focused therapy. There's EMDR. So there's that huge term has a whole bunch of therapies in there.
Yeah.
I do a lot of behavioral therapy because I work with a lot of kids and their parents, and so I work with the parents to help affect behavioral change in kids. And so I infuse that type of therapy in what I do. But the only reason I can do that is because I have a direct pay practice. Because when I was working with insurance, they limited what I could do by what they would pay for. So insurances would not pay for me to do therapy.
Wow.
Yeah, and so as a result, because incentives being what they are, that incentivizes people to only write medicine. So there are lots of psychiatrists who only write medicines, even though they're trained to do therapy. So when I got out of that system, now I can do whatever I want. So I take 30 minutes. We may take 5 minutes to talk about medicine, and then we take the other 25 minutes to talk about to work through therapy or just other stuff. So that's how that works. So the financial system has skewed what is practiced, and I'm working to change that.
That's cool. Yeah, I've been reading a lot about that kind of problem with, psychiatrists not being able to spend any time with their patients or do any kind of therapy and stuff like that.
Yeah,
so,
and they totally can. It's just that a lot of the psychiatrists who work in a system that takes insurance, you're not going to do what you don't get paid for. So if you don't get paid to do something, you're going to stop doing that something.
Yeah.
And so, and unfortunately, a lot of psychiatrists are still employed, meaning there's somebody telling them what to do, and that company that employs them contracts with insurance, and so as a result, psychiatrists will only do what they can get paid for. And then on the flip side, there's some of us who are, trying to do this new model, and it's working and it's wonderful, but it's slow going.
It's what?
It's slow
Oh,
going.
yeah.
It's slow to change.
That makes sense.
Yeah.
Do you ever have people that get psychotherapy from like other counselors in addition to your?
Absolutely. So when I mentioned earlier that I'm big on behavioral therapy, and I use a lot of behavioral therapy, sometimes I identify that a patient needs something more than a behavioral therapy. Psychiatrists are trained in like at least 3 of the solid modalities, but there's a whole bunch of other new types of psychotherapy that we're not trained in.
Yeah.
And so when I recognize what my deficit is, I refer out, and they call it split treatment, basically where I'll do behavior therapy and medications, and then I'll have another therapist to work on other therapeutic approaches.
Okay.
And there are lots of other mental health practitioners. So there's LCSWs, which is a licensed clinical social worker. There are LPCs, licensed professional counselors. There's LMFTs, licensed marriage and family therapists. There's PsyDs, doctors of psychology. There are PhDs, doctors of philosophy, who are also called psychologists. So there are lots of different people that can do psychotherapy and do it well. And so when I recognize that I'm either outside of my expertise or my comfort zone, I absolutely will refer.
Yeah.
And then we try to make sure that we stay in contact so that the patient always knows, has one plan, so that we're not, doing different things.
Yeah. Whenever you do refer out, do those patients always take that advice, or?
Yes and no. It depends on the rapport that you build with the patient. So if I get the patient first and we're working closely together and they feel that they can trust me, there's a higher likelihood of them following my direction, either for medicines and for therapy referrals. sometimes it doesn't work out. So like sometimes I will refer a person to a psychologist or a counselor. They meet and there's not a good match, and so the patient will come back and go, "Oh, I didn't really like that person. Can you recommend somebody else?" And then yes, there is a sliver of patients who go, "I'm not going to go talk to anybody but you. I trust you. I don't trust anybody else." And for those folks, I will go ahead and continue to do therapy, keeping in mind that I tell them if you do something that's out of my wheelhouse, that's out of my expertise, I'm going to press you again to to have somebody else that joins in. But most stuff I can handle. There's some certain things where I'm like, no, that is just not my strength, and so I'm not gonna put the patient at risk because So I'll refer out for that.
Okay, that makes sense. Yeah. Have you seen any significant difference between the improvement of patients who supplement medication with psychotherapy?
Yeah, so it depends on what your, it depends, so I'd say data-wise, it depends on what your diagnosis is. So there's certain diagnoses where psychotherapy is better. There's certain diagnoses where medicines are better. There's certain diagnoses where the combination of medicines and therapy is better than the two parts. So it just depends. It depends on what the diagnosis is. But again, I will always come back to it is always helpful for everybody to have a therapist. I think that just the human condition, we're living in a weird time right now because of the politics and the partisanness of how things are going, that I think everybody needs somebody to talk to because there's lots of alienating things being said and done. And so I would say, yes, everybody needs to have a therapist, and more importantly, keep in mind that, it's part of the human condition that you're going to struggle with finding yourself and finding connection. That's just part of who we are as a human race, I think.
Yeah. Have you ever read any David Foster Wallace?
I haven't, but I'm going to write him down.
Oh, really?
Yeah, tell me about him. Who's David?
He's cool. He actually, it's kind of sad he committed suicide, I think last decade, like around 2008 or so. But I haven't read a lot of stuff, but I've watched like every interview he has on YouTube, and he's always talking about, he usually specifically talks about like America, but yeah, he talks about like how it's difficult in a time where everything is focused on like, what would be the best way to summarize it? Like consumerism to build human connections and stuff like that. And yeah, I feel like it's really powerful, a lot of the stuff that he says, especially because he didn't end up taking his own life.
And it's so interesting. Suicide is kind of a topic that's been brought up again, especially with the last couple of weeks with Anthony Bourdain committing suicide and Kate Spade. And I treat patients who are suicidal, and the way that I was trained and the way that I teach it is that suicide is a coping skill. It's just the worst coping skill you can think of, because it's a permanent solution to a temporary problem.
Yeah, I've heard that.
And so but the problem is if you don't talk about it, it becomes a stigma. So in a sense, we need to normalize the discussion about coping skills. We need to normalize the discussion about how we're living what life is and if life is suffering or not. Because quite a few folks, especially, and it sounds like this guy, Proust, there's lots of other kind of philosophers who think that life is suffering. And if you come from that perspective and you have that worldview, you're going to have a tough time when stressful things come along. And so I would much rather change the discussion so that we're talking about coping skills. How do we deal with the cards that we've been dealt? How do we reframe who we are and what we're going through? Because I think when you reframe it, it becomes a lot more palatable. It becomes easier to manage rather than despairing and then killing yourself because that doesn't actually solve anything. So I'll definitely check this out. I have a running list of books and stuff that when people say, you should read blah, I write it down so that I can come back to it later on. So thank you for that recommendation.
Oh yeah, of course. Yeah, my favorite interview I just was showing my girlfriend. I don't know if there's a specific name, but there's this guy on YouTube posted it called Manufacturing Intellect. And it's just him with like this German girl. And it's cool the way they do the interview because you can tell David is really like, he's stressed on camera. And with he feels the real need to like kind of participate in that sort of consumerism. I don't know. You can see how it's kind of like ironic for him, but it's a really cool interview. Yeah.
Gotcha. Well, I will check that out. Manufacturing Intellect.
Yeah.
On YouTube.
Yeah.
Okay. Man.
I know, right?
That's a lot. Yeah.
Let's see. Did you enter the field of psychiatry with the intention of performing psychotherapy?
Yes and no. I didn't know the term for it. So when I went to medical school, I actually wanted to be a family physician. I thought I wanted to treat everybody from birth to grave and, take care of high blood pressure and that sort of thing. And psychiatry was nowhere in that list.
Yeah.
And so I did that rotation, find out that it was not for me. But what I did like was talking to people. And so in medical school, you have to rotate through each of the different areas. And I rotated through psychiatry, especially child psychiatry, and I loved it.
Yeah.
You get to just sit and talk to people all day. And so, so once I got into psychiatry, and I learned that talking isn't just talking. There's actually a method to the madness. There's a educational scaffolding underneath all that talking.
Yeah.
And that's what psychology and psychotherapy is there's a scaffolding. So it's not just sitting and talking. It's you have kind of a rubric and a guideline to go by towards a certain end. And so so then once I got into my psychiatric training and I learned what psychotherapy was, then I loved it. I thought that was great. So so I kind of fell into it because that's just how it went for me.
Yeah.
So I didn't go into medical school going, I want to learn psychotherapy. That wasn't it at all. It just happens that that's part of the training program. So,
that's cool, yeah. How does it feel knowing that a lot of people nowadays don't get that kind of psychotherapy?
It drives me bananas. Oh, absolutely. So from the patient side, again, everybody should have a therapist.
Mm-hmm.
On the psychiatrist side, there are less training programs that are teaching really good psychotherapy.
Wow.
So as a result, they're pushing out lots of trained psychiatrists who are very good at medication management. Like they're wizards with, chemicals and brain receptors and blah blah blah, but they don't know how to talk to anybody, and that's an inherent issue. Yeah.
Yeah.
And so it drives me nuts. And so so it's kind of a double whammy. Patients don't know that psychotherapy is important because we're not telling them that psychotherapy is important, and then doctors are no longer really being trained in psychotherapy. So there's this, and then unfortunately, because of the way this system works, people give more credence to physicians and less credence to psychologists and therapists. Mm-hmm. And so they don't have the kind of market share or the market power to say psychotherapy is important.
Yeah.
Yeah. And so as a result, it's actually like a triple whammy. Because, And so I'm hopeful that by bringing attention, by doing stuff like this, I'm also we call it clerkship, but I'm a training director, educational director for the new medical school that's going in, and we're going to hopefully...
Oh, the TCU medical school?
Mm-hmm. Yeah.
Oh, yeah, my mom actually works there.
Oh,
That's
really?
Cool. Yeah, she's the director of, advertisement or something like that.
Oh, you know what? That's funny. Yeah, I'll talk to her after this. So we really need to really push the envelope that we need to teach medical students the importance of psychotherapy from the get-go, so that then they can either, if they don't want to do it, which is totally fine, they can refer their future patients to psychotherapy because they know that it's important. So.
Yeah, that's cool. So do you see any significant advantages to having a singular psychiatrist handle both the prescription and psychotherapy?
Do I see an advantage? Yes. So there's a financial advantage, meaning you don't have to spend more money, kind of being dual treated. But it's so case by case basis. Mm-hmm. Because on the flip side, there are certain things that there's certain times, certain diagnoses where you do want two people, like you just do. So I'll give you an example. If I see an 8-year-old male child with ADHD who's throwing fits, totally fine. I can treat that not only with medications, but I can also do the behavior modification. Mm-hmm. But let's say, for instance, that 8-year-old child is the parents are going through a divorce, and that's what's causing the fits. Well, I'll still teach the parents how to deal with those fits, and I'll still treat the ADHD, but I need somebody else to do, if applicable, marriage counseling with mom and dad, so that executive relationship is being taken care of. It may be that I need to get a play therapist to work directly with the child to teach them coping skills. Because when I do behavior therapy with the parents in regards to the child, it doesn't actually teach the child how to cope with the fact that his parents are divorcing. Right?
Yeah.
I need a separate person to do that, because behavior therapy generally makes kids very mad, because I'm teaching, I'm basically saying when they throw a fit, you ignore them and you do certain things, and kids don't like that, right?
Yeah.
So I need a separate person that can sit down with the child and say, hey, I know Dr. Dixon said, you're going to have to go to timeout. How does that make you feel? Because I can't do that because of the relationship between me and the child at that point, right?
Yeah.
And eventually that all changes, meaning the kid will come around and we'll be best friends, but not initially. And so it's actually helpful to what we call triangulate that care for here I am over here, here's a marriage therapist working on the executive relationship, here's the play therapist working on coping skills, and between all three of us, we can cover all the different areas.
Yeah.
But that's really hard to do. And if you think about it, me as a singular psychiatrist or a singular clinician, I can't do all three of those things. And so in that case, it's actually helpful to have more people. Yeah, it's more financially intensive, but it's what's best for the patient. So that's kind of two different examples where I can do all the therapy if it's really straightforward, but if it's really complicated, it's helpful to have other people involved.
Okay, what do you think of medical marijuana being prescribed for psychiatric?
Oh, Lord have mercy. Yeah. So I am unique in that I went to a really great training program at the University of Kentucky. And on faculty, so in the world of medicine, you learn from your attendings. You learn from the doctors who have come before you. And I had really good doctors who did not use much medication in helping kids feel better and helping heal families and that sort of thing. And so I was taught that no person is born with a Ritalin deficiency. No person is born with a medicine deficiency. You use a medicine to basically bridge you from one place to another. And that's how I still practice to this day. Well, when it comes to marijuana, my philosophy is less is more, so less medication. So for us to go, hey, let's add marijuana to the list of things that we can use to treat people, I scream, no. Yeah. That's adding more medicine, and whether it's a medicine or drug or whatever, I don't want to add more. I want to do less, and so I would say that I'm never going to be a fan of marijuana. Same thing with ketamine. I don't know if you've heard of that one.
Oh, actually,
yeah, so ketamine, ketamine. It's a kind of hallucinogen that is being used more and more for PTSD.
Oh, wow.
And there's good data that shows it works, but it's another drug that we're adding. And I'm a minimizer. I'm a less is more kind of guy.
Yeah.
So what I would say is, in my experience, that most people haven't done all the other stuff first before you get to marijuana. So, are you consistently going to psychotherapy? Do you have a job that you like? Are you surrounded by and supported by people that are supportive and positive? Are you taking the medicines as prescribed by your psychiatrist, if applicable? Are all of your medical needs and concerns taken care of? Do you know what your passion and purpose in life are? Now, if you've covered all 5 of those areas and it's all great, and you're still having issues with anxiety, or you're still, having something that would necessitate being on marijuana, okay, fine. I'm not going to write it for you, but I won't stand in your way, in so many words. Yeah. But I have a feeling that people are trying to shortcut all those other things, right? They go, oh, I've tried all these SSRIs, all these other serotonin medicines for my anxiety, and it's not working, and the only thing that works is weed. And I'm like, okay, well, tell me where you're working. Oh, I hate my job and it's terrible. Well, that's where the issue is. You're anxious because you hate your job, or you're in a toxic relationship, or you are, any number of things. To me, medical marijuana is a Band-Aid. Let's actually go after what's causing the anxiety and treat it that way.
Yeah.
So that's my take on it. A lot of people are like, well, that's not fair. You're making people suffer. No, I'm not. You have to be... mental health care is hard. You have to be ready to change, and a lot of people aren't ready to change. They would much rather take a pill or self-medicate with alcohol or marijuana than do the hard work. Psychotherapy is hard work. It's some of the hardest work you'll ever do. Yeah. So that's where I think I think the messaging gets really, really blurred with medical marijuana, and so I would say no. Let's do those things that actually work, rather than just getting high all the time.
Yeah. Okay. I think that's a good answer. Have you perceived any significant differences in the way insurance covers patients' care since the passage of the Mental Health Parity Act?
No, it doesn't. That's parity in name only. Is how I put it. So private companies, so insurance companies are private companies. They can do whatever they want. Let's just be super, super clear about that part. And so even though the government tells insurance companies, hey, you need to cover mental health care at the same rate that you cover medical health care, there's no kind of governmental arm that really enforces that, because you can't really go behind the closed doors and see what's going on, in so many words. Yes, there are metrics that the government requires insurance companies to submit so that the government can try to catch that stuff. But I mean, they make up their own rules and they change them all the time. So, and the government doesn't have enough money to audit all that process. So no, there's still times where people are getting denied claims or having to jump through really big hurdles to get their mental health care covered. So I haven't seen it. I think it's all smoke and mirrors.
Oh yeah. Are there any changes that you think could happen in the insurance system that would help with like antidepressant addiction and stuff?
I don't think so, because honestly, the mental health care is different than medical care in that it's long term. So it's very, I wouldn't say chronic, because that's not the word I want to use, but in order to get people feeling better, medicine-wise and psychotherapy-wise, it may take 3 to 6 months. And psychotherapy, it may be every week for 3 to 6 months, which is way different than, hey, I broke my leg and I'm going into the OR, and right. So that's just a one set fee. Whereas in mental health, I mean, it's a longitudinal thing, and that theoretically could be really, really expensive, depending on how you price it. And so no, I don't see them becoming. I don't see insurance companies going, oh, I'm going to do the right thing and try to cover this. I think they're going to continue to obfuscation is the term I use, where they basically kind of go, oh, we're not really here, that sort of thing. Look over here while they go do this stuff over here. So that's not going to change anytime soon, because there's no financial incentive for them to do the right thing. So
that makes sense. I think that's all my questions,
Awesome. So then what do you do with all this information? Do you just write up a report and submit it to your teacher, or what happens?
I'm going to write an article on it, basically. The topic is about how, like, the insurance system in the U.S. might be contributing to, like, I don't know, problems with the psychiatric system and, like, mainly antidepressant addiction because of how people don't get insurance for certain things, but they do for other things, and so whatever is available to them, ends up being drugs a lot of the time.
Yeah, so one analogy that I like to use, and then I'm going to run to my car and get my book, because I wrote a book.
Oh, yeah.
And I'll bring that to you. So the analogy that I like to use, because people go, well, do medicines really work? So what part of the Metroplex do you live in? Are you in Fort Worth? Or
I do live in Fort Worth,
okay. So I'm sure you've been on I-35 at some point.
Oh, yeah.
Okay, and it's the worst highway in America. Yeah. So if you think about it, when you think about traffic, so in an area of traffic and congestion and terribleness, how do you fix that? Well, at some point you get together a team of experts, probably engineers, but a team of experts who look at all the different patterns, they assess those patterns, and then they put together a plan to increase the number of lanes, figure out where people are going, yada, yada, yada. And that sometimes is a 2 to 3 year, and then they start the process of actually, excavating and building and redirecting traffic and blah, blah, blah. Yeah. And over the course of, 2 years or so, 2 to 3 years, the traffic starts to flow more freely, right? And you go back, yay, everything is great.
Yeah.
To me, that's what an antidepressant does. So it moves serotonin around in your brain to help traffic flow more freely, and it's a process. It takes a long time sometimes for that to work. Well, I'm not telling people on just like with the when you're doing wide scale construction, you're not telling people how to drive, what to do, da 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 da. That's where the psychotherapy comes in. So even though we can widen the lanes, we can do all that stuff that kind of structurally, you still need some kind of mechanism to teach people how to drive and how to be courteous and da da da. And that's where psychotherapy comes in. So in that analogy, so the serotonin helps kind of free up neural pathways so that you can move easier and blah 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 blah. But then you need the psychotherapy to say, you know what, when people say this to you, it's not always a requirement. Learn how to delegate, self-care, take care of yourself first, blah, 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 blah. So the two work together. Because imagine if you still had a 2-lane I-35 and you had somebody telling you, okay, do your self-care, da, 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 da. Well, it's not going to work because your lanes are still so constricted and there's, the traffic is still terrible. You need to add more lanes before you can get any kind of traction. And so, there's a much better way that I explain the analogy to patients but it's a Sunday and I don't,
That's okay. I think I understand. Yeah.
Okay. Yeah. And so that's where the two are actually very synergistic with therapy and medicines. So, and like I said, there are very few things where medicine is the only option. Schizophrenia, you need to be on medicine, period. There's no way to psychotherapize yourself out of hallucinations for true organic schizophrenia. And the medicines work not perfect, but they work very, very well. Same thing with classic ADHD, with inattention. Yes, there are other psychotherapeutic modalities that are helpful, but being on a stimulant is hands down better than anything. When it comes to depression and anxiety are very schema related. It's very dependent on how you see the world. So medicines won't always do what you think they're going to do. That's something where you need to sit and talk with somebody about how you see the world, and that's very psychologically heavy. And so you need to see that therapist. And it could be that just seeing a therapist is better than taking a medicine. So yeah, it just depends on the situation. So I'm glad you asked very good questions. I don't know how you ask questions like this as a high schooler. That doesn't make any sense to me because adults don't even ask these types of questions. So so let me run to my car real quick. I'm just parked right out back. It'll take me 2 seconds, and then and I'll get you a couple copies of the book. So I'll be right back.
Thank you.
Oh, no problem.